Welcome and good morning, good afternoon, good evening, wherever you are. My name is Eline and I will be the moderator of today's webinar. First of all, thank you so much for joining us today. I hope you're all doing well and are staying healthy and safe in these times. So the topic of today's webinar is the use of brain and spinal cord atrophy in clinical practice for multiple sclerosis. We will focus on the technical aspects, the clinical value, and the implementation to clinical practice. So I'm really delighted to introduce our speakers of today. Our first speaker is the amazing Dr. Àlex Rovira, who is Director of Neuroradiology at the University Hospital Vall in Barcelona. He's also Professor of Radiology and Neuroimmunology at the Autonomous University of Barcelona and past President of the European Society of Neuroradiology. He's joined today by his wonderful colleague, Dr. Jaume Sastre-Garriga, who is neurologist at the University Hospital Vall and board member of multiple Amass-focused networks. Dr. Rovira and Dr. Sastre-Garriga are both steering committee members of Magnims, a European network of academics that have made major contributions to defining the role of MRI in the diagnosis and monitoring of MS. And last but not least, from icometrix, we have Dirk Smeets, our Chief Technology Officer and powerhouse. And now I leave the word to our speaker, starting with Dr. Àlex Rovira.
Know that MRI is a very high sensitive tool for detecting MS plaques in the brain and in the spinal cord. This is particularly true at the level of the white matter. It provides or it helps to establish an early and accurate diagnosis of this disease. It also contributes to the prognosis of this disease. And also, thanks to different markers, we can quantify the degree of disease activity and severity. Nowadays also plays a very important role in monitoring and predicting treatment response. So there is no doubt that this MRI is the most important tool that we have for diagnosis and monitoring MS. In fact, we are quite good in assessing the focal inflammatory activity that characterizes this disease. And MRI is commonly used not only in research, in clinical trials, but also in clinical practice to assess the degree of inflammatory activity and in order to assess the efficacy of the different disease-modifying treatments that we use in clinical practice. This is an example of a follow-up in a patient, follow-up MRIs obtained in a patient during several years, a patient that received different disease-modifying drugs, and we can see the profile of the new gadolinium-enhancing lesions, new T2 lesions, and this obviously helps the neurologist to know the efficacy of these drugs. But also we have to keep in mind that MS is not just an inflammatory disease. It's a disease with two overlapping pathogenic components, an inflammatory component that predominates in the early phases of the disease, and a neurodegenerative component that, although predominates in the progressive phases of the disease, is already present at the onset of the disease. And we know also, according to many studies that have been published in the last 15 to 20 years, that probably the best tool to assess this neurodegenerative component of the disease is by assessing the brain volume, which is a marker of brain atrophy. And also we know that this measure correlates quite strongly with the disability worsening that characterize this disease. Okay, so if we follow a patient for a long period of time, it's relatively easy to assess the degree of brain atrophy. And this is an example. This is the MRI obtained in a patient at the onset of the disease. We can mention that there is no atrophy at all. And this is the follow-up after 10 years, in which we see the increase in the ventricular size and also in the SALCI, indicating brain volume loss. However, if we want to assess the degree of brain atrophy during a short period of time, or on a yearly basis, for example, it's impossible to make this assessment by visual inspection of T2 or T1 weighted sequences. We need some tools that quantify the degree of brain volume, the degree of brain atrophy, as, for example, we did in this particular patient that we follow during 4 years. We can see that at the first years there is almost no brain atrophy, while in the last MRI the degree of brain volume loss was much faster, indicating development of significant degree of brain atrophy. So it's clear that if we want to assess the degree of brain volume, we need some tools in order to quantify this measure. But the question is, why brain volume metrics or spinal cord metrics are not widely used in clinical practice? And I think that there are several reasons. First, are technical reasons. It's clear that if we want to apply the different tools that are available, we need a high quality MRI with a standardized protocol. This is really mandatory. We have to also keep in mind that there are several confounding factors that have an impact on the measures that we obtain with these tools. Also, we have also to keep in mind that not all the tools that are available produce reliable results. So we have to know which is the quality of all these tools. And finally, the good tools are not always available at all centers. So that's one of the reasons why we don't use these tools in clinical practice. But there are other reasons, such as practical reasons. We know that radiologists, neurologists, we are all very busy, and sometimes it takes an additional time to perform these measures, so we don't have time to do it. And also the cost, who is going to pay for that additional effort that we need to do in order to provide these measures? Obviously, I will not discuss these reasons, but it's clear that any tool that we want to use in clinical practice should be very fast and not time-consuming. Last but not least, although I will not discuss these concerns, this is the topic for the next speaker, are the clinical ones. So the question is, how should I interpret the numbers that we get with these tools, and which is the impact of these measures in patient management? But this is another topic. So let's focus on the technical reasons, which is the topic of my presentation. And the first is about the standardization. Which sequences, which protocol do we need to perform in order to be able to apply, to use the different tools that I will comment in the next few minutes. So the most important sequence is an enhanced T1 weighted sequence. But depends also on the type of sequence that we use to obtain these images. It's different if we use, for example, a 2D T1 spin echo sequences, particularly if obtained at 3 Tesla. The contrast between gray and white matter is really poor, and any tool that tries to segment the gray and the white matter will not work. So we need to perform heavily T1 weighted sequences, such as the ones that you can see here. The 3D MP rates is an example, or a variant in which we use an inversion recovery pulse that increase the contrast between gray and white matter. And this will facilitate the implementation of segmentation tools that in this example can detect, can delineate automatically the basal ganglia or the thalamus. So we need a heavily T1 weighted sequence, ideally obtained on a 3D acquisition in order to obtain good results. But not only T1 weighted sequences are necessary, we also need a T2 weighted sequence, ideally a T2 FLAIR sequences, and also acquire with a 3D sequence. So the 3D T2 FLAIR is an excellent sequence to identify the T2 lesions, the focal T2 lesions, because These focal lesions produce an artifact when we try to segment, for example, the gray or the white matter, because most of these focal lesions with these tools will be assigned to gray matter. So if we have, for example, a patient with a high T2 lesion load and we apply these segmentation tools, we will have a false results of high gray matter volume. So we need to get rid of these focal lesions, and there are several tools that are also fully automated, the so-called T2 lesion filling tools, in which we mark these lesions and then we perform the segmentation in which we get rid of this problem. So both T1 and T2 weighted sequence are really important, particularly if we are interested in assessing regional brain volume, gray or white matter. The second part is to discuss the different tools that are available. We have three different types of tools. We have the academic ones that have been used for many years, particularly in research centers or for doing research studies or clinical trials, in which different programs provide with different softwares that are designed for a specific task, such as the FSL library or the SPM. They are reliable, they are usually free, but they have the inconvenience that they are not friendly at all. It takes, you have to know a little bit about IT issues, and also is time consuming. So it's good for research, but it's not, they are not ideal to be used in clinical practice. Second, we have different commercial tools. Different companies have developed softwares that are available to generate these metrics on cost image basis. So the advantage of all these commercial tools is that they are extremely friendly. They are not time consuming, but the drawback of all of them is that obviously you have to pay for this service. Finally, the big MRI vendors, they are now in the phase of development of softwares that will be implemented online together with the acquisition. They will be obviously not time consuming, but still most of these tools are under development and still not completely available for clinical practice. So these are the different tools. You have to be familiar with these three options, and you will be then able to select which is the best option for your question. The second point I would like to discuss are the different confounding factors that obviously will affect the measurements that we obtain with all these tools. We have factors that can be classified as physiological or physiopathological, such as, for example, the age of the patient, of the subject, the gender, the head size. All these factors are not really a problem because in all these tools we have ways to minimize or to get rid of these problems by a normalization process. But in addition to that, there are some other factors that can in some way produce some fluctuations in the degree of brain volume. Although these fluctuations are in general quite minimal and do not really affect when we follow a patient for a period of time of 1 year, for example. In addition, there are other factors that have been shown that accelerates the degree of brain volume loss, such as smoking, heavy alcohol intake, different vascular risk factors, even genetic factors have been shown to accelerate the brain volume. And obviously, when we try to apply these metrics in clinical practice, we have to be aware of these factors. The second classification of these confounding factors are those related to the MS, to the disease. We already mentioned about the effect of the focal lesion. We have to get rid of these focal T2 lesions in order to obtain reliable measures of the gray matter. But what I would like to discuss is the pseudo-atrophy effect that I think is a very important effect that we need to know in order to properly interpret the results. And finally, there are factors related to the MRI acquisition. I will not go into detail about that, but I think that the most important measures that you have to keep in mind is that whenever we have the intention to assess the brain volume, particularly longitudinal studies, we have to obtain the MRIs using the same protocol, using the same coil, the same head coil, and ideally the same magnet. And with this, we will minimize all the different confounding factors related to the acquisition of the image. So in general, all these confounding factors produce a barrier to the use of brain volume in the real world. So at the end, a brain volume change that we can identify with these tools is the sum of true atrophy, true brain volume loss, plus the presence of these fluctuations, physiological variations, and finally to the software errors. All the tools that we can use for this purpose have some errors that obviously should be less than the expected change in the brain volume over the period of time in which we assess this volume, these changes. Also, there are some variations due to the image acquisition, errors to the image acquisition, and at the end, the change of the brain or spinal cord volume is the sum of the true atrophy of these structures plus all these factors. And it's extremely important to minimize the contribution of all these confounding. So let's talk a little bit about the pseudo-atrophy effect. This is a very well-known effect described some years ago. And this effect is related to the effect of the anti-inflammatory drugs. The anti-inflammatory effect of most of the disease-modifying treatments have this anti-inflammatory effect. And this, particularly in patients with a high degree of inflammation, produce in accelerating the brain volume loss once we start the therapy. So pseudoatrophy is the consequence of the resolution of this high inflammatory activity with these drugs. And then the consequence of that is that there is an appearance of brain volume loss, particularly relevant within the first 6 months or the first year after the onset of the treatment, that could be interpreted as brain atrophy. We also know that this effect is more confined to the white matter and not to the gray matter. And this makes gray matter volume change a more reliable marker of the neuroprotective effect of a treatment. We know that measuring the gray matter is a little bit more difficult in comparison to the measures of the global brain volume, but is more clinically relevant, as will be discussed in the next presentation, and also is less sensitive to this pseudoatrophy. But another way to minimize the pseudoatrophy effect, particularly if we are interested in assessing the global brain volume, is the timing of the MRIs in which we will assess the changes in brain volume. The typical design in some clinical trials and also in clinical practice is that we obtain a scan, a brain MR, before the onset of a specific treatment. And then we repeat this brain MR, usually after 12 months after the onset of this treatment. And we know, and nicely shown in this cartoon from Sivadinov, is that during the first 6 months after the onset of the treatment with an anti-inflammatory effect, there is an acceleration of brain volume loss in patients treated with a high anti-inflammatory drug. Then, after these first 6 to 12 months, there is an opposite effect. So those patients treated with these drugs have a reduction in the brain volume loss compared to patients receiving placebo. These are data taken from different clinical trials. So a very simple way to get rid of this effect is to ignore the brain volume measures obtained on an MRI scan acquired before the treatment onset. So it's very important to re-scan the brain after 6 to 12 months after the onset of the treatment, and then use this new MRI as the new baseline in which we will compare any brain volume change after 1 year or 6 months or after several years. So remember, it's important to exclude brain volume change during the first months after treatment onset. If we look at the different clinical trials published, we can see how the pseudoatrophy effect impact the results of these trials. Let's focus on the Natalizumab trials in patients with a relapsing remitting MS forms, the AFFIRM or the Sentinel trial. And both trials that they compare, they assess the effect of this drug in preventing brain volume loss during a 2-year period. Both trials were negative, so they could not demonstrate any positive effect of this drug in preventing brain volume loss. However, if we analyze in more detail this data, we can see that if we ignore the changes that occurs within the first year that show a greater atrophy in patients treated with natalizumab, if we ignore that and we only assess the changes that occurs after the first year, there's a significant reduction in brain volume loss in patients treated with natalizumab. This has been shown in both trials. Another example is the design of the Clarity trial in patients with relapsing remitting MS treated with cladribine, in which at the beginning, when they assessed the brain volume changes over the first 6 months, there was a negative effect of the drug in preventing brain volume loss. While when they ignored the 6 months period, then there was a significant positive effect of the drug in preventing the brain volume loss in treated patients. So this is 2 examples of the pseudoatrophy effect and how can we minimize or get rid of that. Another point is which are the different tools that we have for assessing brain atrophy. And I think it's important to classify them into 3 main groups. Those that are based on a segmentation tools. The second group are those based on a registration tools. And finally, more recent tools combine both segmentation and registration-based. The segmentation-based tools are ideal for assessing cross-sectional studies, for assessing not only the global brain volume, but also the regional brain volume, white or gray matter. The registration-based tools are ideal to assess longitudinal changes, but only for global atrophy. We're not designed to identify changes in specific areas of the central nervous system. More recently, some tools have been described in which they combine cross-sectional segmentation and longitudinal registration-based tools. And these tools in different papers have shown to be robust, reliable, and sensitive to changes over time for assessing regional changes of brain volume in longitudinal studies. So let's see an example. This is an old example that we obtained in our lab using a segmentation-based tool. There are some also available search in which we segment the brain. We normalize this brain volume according to the head size, and then we can obtain measures such as brain parenchymal fraction or the normalized brain volume that are ideally for assessing cross-sectional studies. With the same tool, we can segment specific regions of the central nervous system, the white matter, the gray matter, the CSF, or specific structures such as basal ganglia or the thalami, based again on these segmentation tools, ideally in cross-sectional studies. The second group are those that use tools based on registration between scans obtained at 2 different time points. The segmented brain images are used to find local atrophy changes measured on the basis of the movement of the edges between the images. This is an example. This is the baseline examination. This is a 1-year follow-up. We apply these registration-based tools, in this example with the so-called Sienna software. And with that, we obtain at the end a measure in percentage of the changes of the global volume of the brain. We can analyze this depending on the interval between the two scans, and this is a common measure used in clinical trials to assess the neuroprotective effect of different drugs. More recently, some tools have been described in which they combine segmentation and registration-based algorithm. With these tools, it has been shown that the error of these tools in assessing longitudinal change are minimized, and also they are highly sensitive to detect changes over relatively short periods of time. They are ideally designed to assess regional brain volume changes, particularly gray matter volume change. Let me finish my presentation by talking about spinal cord atrophy that has now become also an important topic because we know that particularly in the progressive phase of the disease, spinal cord atrophy is clinically relevant. We can measure this spinal cord atrophy, has a strong correlation with disability in this particular group of patients. And although in some ways also present in the relapsing forms of the disease, is greater in this progressive. One of the main advantages of using spinal cord atrophy instead of brain atrophy for assessing this group of patients is that the spinal cord atrophy is faster compared to the brain volume loss. It has been calculated based on this meta-analysis published a couple of years ago that this annual rate of spinal cord atrophy is around 1.8 per year. And remember that the brain volume loss per year is around 0.3, 0.6 per year. So it's almost more than twice faster in the spinal cord. And this means that we have the option to be more sensitive in detecting changes over time. And in fact, nowadays, spinal cord atrophy is used as a secondary outcome measures in clinical trials, particularly in the when trials that include progressive MS patients. So how can we measure the spinal cord atrophy? We need also to obtain high quality, heavily T1 weighted sequence of the spinal cord. And there are several tools that can more or less automated detect the margins of the lesions. We can segment of the cord. We can segment the cord. We can calculate the volume, the cord length, and with that we can calculate the cord cross-sectional area, which is the measure that we use for assessing the degree of spinal cord atrophy. To do that, obviously, we need to perform a 3D T1 weighted sequence of the spinal cord, something that is not included in the standardized protocol that we obtain in clinical practice. But on the other hand, also has been demonstrated that we can use the 3D T1 weighted sequence that we obtain to calculate the brain volume to also assess the spinal cord atrophy by measuring the spinal cord area at the proximal segment of the cervical cord. So it's important to use a field of view that covers at least to C3, C4, and with that we will be able to also calculate the spinal cord cross-sectional area using a brain T1 weighted sequence. This strategy saves a lot of time, has some drawbacks because brain acquisition, there is some distortion of the spinal cord, but usually it gives some reliable results to obtain this measure. This is an example This is a sagittal 3D T1 weighted sequence of the brain, and we apply a tool that calculates the spinal cord volume, and you can see how nicely we can assess this using a brain T1 acquisition. Unfortunately, if we have a look to the results from different clinical trials that use spinal cord atrophy as an outcome measure, all of these studies, some of them phase 2 trials, most of them in fact, show negative results. So all these trials could not demonstrate any positive effect of the tested drug in preventing spinal cord atrophy. But remember again that most of these trials were phase 2 with a limited number of patients that obviously probably were not designed to identify any effect of these drugs on the spinal cord atrophy. Another problem, and this has been nicely described in this paper published a couple of years ago, is that spinal cord measures are based on segmentation-based techniques that are probably not the best tools to assess longitudinal changes. Also, remember that the spinal cord is a small structure. The resolution of the images that we obtain are not very high. And also the spinal cord has a lot of movement, and sometimes the measures that we obtain in these studies are not perfect. And also, as I mentioned before, probably we need a large number of patients, order of hundreds or even 1,000, in order to detect a significant effect of these measures in clinical trials. However, it has been recently described another tool to assess spinal cord atrophy. Is based on a registration-based technique similar to the ones that we use for assessing global brain volume changes in longitudinal studies. It's based also on the boundary shifts between the cord in 2 different MRIs. And with that, this has been published recently by the Mangrim's group. This technique improves the way to differentiate between healthy controls from MS, and also to discriminate between patients with or without disability progression. Also, the error of this tool in assessing changes over time is significantly decreased compared to the classical registration-based technique. And also, it has been calculated that the sample size required to identify a treatment effect using this registration-based technique of the spinal cord is significantly decreased compared to the classical segmentation-based. So I will finish by mentioning some of the statements and recommendations that we published in our recent paper, published in Natural Review of Neurology. These are the recommendations made by the Mangrim's group, in which we mentioned that appropriate management of several scanner-related factors is essential to ensure the reliability of brain volume estimates, particularly if we want to use these measures individual level. We also need to manage properly the physiological and physiopathological factors that I mentioned before. Also, we know that brain volume measures are highly dependent on the software that we use, so we need to know the error of these methods, how sensitive they are in assessing changes over time. And at the end, it's also important to mention that still we need research to validate all these tools in MS and to assess their clinical value, and hopefully we will be able then to use more frequently these measures in clinical practice. So I would like to thank all the MRI team at the Vall d'Hebron Hospital, also the MS unit led by Professor Montalban, and in which also Dr. Jaume Sastre-Garriga plays a very important role. Thank you very much for your attention.
Good afternoon. Thanks very much for the invitation to be here in this webinar. Thank you very much for kind words of Professor Rovira at the end of his talk. And I will be talking on mostly the clinical implication and the clinical value from the point of view of a neurologist of brain volume in multiple sclerosis. So these are my disclosures, and also I need to disclose and to thank all the work that has been done together by the Magnims group. You can see here the members of the steering committee. Next, I need to disclose also that most of the papers that I'm going to cite, or a good bunch of the papers that I'm going to cite, are papers either produced by this group or by our own research lab. And this is not because the other papers are not good enough, but that they are the papers that we have produced are more at hand, and I know them much better. But again, the choice of the references is mostly done by my hippocampus. So this is the outline of my talk. First introduction, then the natural history, then clinical correlations, evidence of treatment effects on atrophy, and finally, the relationship between atrophy and response to therapy, and whether we can implement these in clinical practice or not based on the evidence that we have, save all the impediments that have been very nicely discussed by Professor Rovira. So brief introduction, and I'm going to write in all letters these some sentences that we were taught at the medical school or even at the beginning of our residency, and see how this has changed in recent years. We were taught that multiple sclerosis is a pure demyelinating disease without axonal injury, and the main pathological hallmark was these sclerotic plaques, mostly periventricular, and that outside these areas, everything was fine. The main components of the pathology were inflammation, demyelination, gliosis, but this was not a recent discovery, but a reappraise that axonal loss was present in people with multiple sclerosis. And as I say, even though it was very beautifully reappraised by Trapp and co-workers, but also Ferguson and co-workers 1 year before in brain, axonal loss is present in multiple sclerosis early from disease course, and also is related to acute inflammation. So it's not true that MS is only a pure demyelinating disease. Another thing that we were taught was that lesions in MS are patchy distributed, and that outside those patches of lesions, these are very early depictions of the pathology of MS. Outside these patches that we can see very beautifully drawn, everything is fine, as I said before. But this is not true, and I'm showing a paper that we published some time ago just as an example in Archives of Neurology. At that time, we looked at the spectroscopy of normal appearing white and gray matter, and we looked at the different metabolic components, and we found that those metabolic components in normal appearing tissue were already decreased, in this case in people with primary progressive MS compared to control subjects. So this was normal, just appearing normal, but was actually pathological, and also because those decreases were also associated with clinical findings. So there's a diffuse neurodegenerative phenomenon going on not only in lesion, but also across the tissue in patients with multiple sclerosis. And this doesn't mean that lesions are not relevant, are important, are crucial for diagnosis, are also crucial for predicting disease evolution. And we know very well from all the meta-analysis by Maria Pia-Sormani, in which she showed, for instance, that the effect, these are different trials, the different blobs, each blob is a trial in which they show that if you know the effect of a particular drug on the appearance of new lesions, this is the MRI effect, you can nicely predict the effect of that drug on the appearance of relapses. So lesions are very useful, and we use them a lot in clinical practice. However, and this is a paper from the Magnims group in which we studied the MRI features of benign MS. You can see here 2 rows of patients with multiple sclerosis. One row is of patients with secondary progressive MS, EDSS above 6, and the other is a group of patients with benign MS. This is long disease duration, very low, below 2 EDSS. And if you tell me which line is which, you will do me a favor because I cannot remember right now. And by the way, it's very difficult to differentiate only by the looks of the lesions which one is which, meaning that lesions are very useful, they tell us a lot, but they clearly don't tell us the whole story of what's going on in the brain of our patients. And what I'm trying to tell you in the next few minutes is that atrophy can help us in this role. So I promise you the natural history of atrophy and multiple sclerosis was the second part of this talk. And first, we need to know that obviously atrophy is going on not just in patients with MS, but in all of us that we are now in this webinar. And this has been very nicely shown last year by Marco Mattaglini and co-workers. Again, a Magnins effort. You can see here that the decrease per year in brain atrophy is present from very early in the age of a particular person, and it accelerates over time. So it's something that is going on in not just in patients, but also in healthy subjects. But what do we know from many studies, and again, I'm showing you a Magnum study, but this has been shown repeatedly, is that brain atrophy is occurring yearly at a faster pace in people with MS as compared to healthy subjects that you can see here in this red line, and not just in patients with progressive forms of the disease, but also in patients with relapsing and early phases of the disease. I'm talking about brain atrophy in general, but we look into the different compartments, and mostly I'm talking about gray and white matter. What we have seen in also a number of different studies coming from different groups, it's been very much confirmed, is that the area that is most affected, this is a study in CIS patients performed by our group. Francisco Pérez Miralles was the first author here, and what we saw is that there's a decrease in brain volume in the first year after the CIS, and this is mostly due to gray matter atrophy loss. This is in CIS patients, so very early in the disease. But Michela Tiberio, using data from the Queen Square cohort, showed exactly the same in early relapsing remitting MS, decrease in brain volume, and the decrease that we could observe was only in a gray matter fraction, whereas white matter fraction was unchanged over 2 years. We also found the same pattern using the early PPMS cohort in Queen Square, where there was a significant decrease over 1 year in brain volume loss in patients with early PPMS, and this decrease was only felt in gray matter compartment, whereas white matter was unchanged. So we know there is significant brain atrophy going on in patients with MS across all disease types, particularly in gray matter, but also we know this is a meta-analysis of voxel-based morphometry studies that we perform in collaboration with other groups, in which we show that this gray matter damage is more prominent in different areas of the brain, particularly in the basal ganglia bilaterally, but also in the pre- and post-central gray matter cortical areas bilaterally, and in the cingulate gyri bilaterally as well. And this has been confirmed by other groups using other techniques. So we know that there is this process of neurodegeneration going on, that we can measure this process, but is it relevant for our patient? And this is what I'm going to try and show in the next slide, the clinical correlations. This is again the same study that I showed you some slides before. In this study that we performed using the CIS cohort in our center, we scanned the patients at baseline, so a few weeks or less than 3 months after the first episode of neuritis, myelitis, whatever. And then we rescanned this patient 9 months later. And you can see here in all patients the amount of brain volume loss after these 9 months. And then you can see in red, yellow, and green this same group divided in patients developing a second attack over 4 years of follow-up, patients developing MS, but only because of the appearance of new lesions, and in green, patients which didn't develop a second attack nor any new lesion. And you can see that already from the development of atrophy in the first 9 months, you could predict what was going to happen clinically over 4 years. This is in CIS, in the first 9 months following the first attack, in terms of development of a second attack, but also you could look at the same data, but coming from Queen Square, the CIS cohort there, in which looking at the first year PVVC, this is brain volume loss measured by Siena, and then looking at EDSS after 6 years, you can see that patients that are going to be EDSS more than 3 have already significantly developed atrophy in the first years, as I say. And looking at the different compartments, this was done by Catherine Dalton, published in Brain. This is again the CIS Queen Square cohort. The compartment which was more rewarding in terms of clinical correlation was gray matter as compared to white matter. So the picture is very similar. So brain volume loss is associated with clinical endpoints and particularly gray matter. And you can tell me now, okay, this is just looking at brain volume loss separately from other outcomes. And the good thing is that we also have data showing us that the predictive power or predictive value of atrophy is not just alone, but also it fits very well in models together with other very important parameters such as EDSS worsening or appearance of new lesions. And this is what we're showing in this 10-year follow-up study from the MANNIMS cohort. So development of atrophy over 1 year together with lesion volume changes were predictive of EDSS status after 10 years. And this was in a group of relapsing remitting MS patients mostly, but we found exactly the same looking at a cohort of PPMS patients as well. More recently, in a more sophisticated approach, but looking at mostly the same outcomes, Maria Pia Sormani, using data from the Freedom study, have been able to develop a tool to predict whether our patients are at risk of worse disease evolution in terms of EDSS progression by measuring the actual brain volume and the expected brain volume according to other clinical and baseline demographical parameters like T2 region volume, EDSS, age, MS duration, and male gender, in the way that the same measure of brain volume, in this case, these two patients have exactly 1,500 centimeter cube of normalized brain volume, but for the clinical parameters, patient one is with a low expected normalized brain volume, whereas patient 2 is at a high expected brain volume. And if you classify these patients, the patient in this way, these disability risk groups are completely different in terms of disease evolution over the 2 years of the Freedom study. The patients that with a higher risk have a 37% confirmed risk of disease progression compared to 20% in the low risk. By the way, and we will see this in a minute, if you treat this patient, in this case with fingolimod, you are able to change the fate of these placebo groups by, this is very fashionable now, by flattening these lines. So we know that there's atrophy ongoing in MS. that we can predict disease evolution by using atrophy measurements, but can we change that evolution of atrophy? And we can use this to measure the effect of our drugs. This has been to a point of many controversies. I'm showing you this is an old one by Rick Rudick and Elizabeth Fisher, going for the yes, using brain atrophy as the gold standard of effective therapy, Mara Roca and Massimo Filippi for the no. And they went for the no mostly because of what Professor Rovira has said some minutes ago. This pseudoatrophy effect will make very difficult and a confusing factor when measuring what happens in terms of brain atrophy when we start anti-inflammatory therapy. Professor Rovira has shown the profound effect of that natalizumab has, particularly in the first years. This is a 3-year follow-up of patients treated with natalizumab, and you can see that patients in red with positive gadolinium baseline have a profound decrease in brain volume, which later on normalizes compared to the gadolinium negative, meaning that what happens mostly at the beginning is a pseudoatrophy effect. This is not only happening in natalizumab, by the way, is also happening in interferon. We showed this in a paper by Anca Vidal-Jordana in 2016 in the Journal of Neuroimaging. So all anti-inflammatory drugs have this theoretic potential to induce pseudoatrophy. But pseudoatrophy is not a problem that is unsurmountable. So even for drugs with a very important anti-inflammatory effect, like for instance fingolimod, you see that important decrease in gadolinium-enhanced lesions after 12 months. These drugs are able to improve atrophy parameters. So in spite of being very anti-inflammatory, they are able to stop to decrease the rate of atrophy progression already from 6 months. This is from Freedoms. This is data not only for fingolimod, but you can see this also for alemtuzumab. In spite of being more anti-inflammatory than Rebif, as you can see in this graph here, they still protect from development of atrophy. And this, for instance, has been even more recently shown. This is data with ozanimod here and compared to interferon, and in spite of being more anti-inflammatory, is also more protective in terms of brain volume. So pseudoatrophy effect is an important effect, is there for all types of drugs, but it doesn't prevent some drugs from being effective and a decrease in brain volume loss. If you want to look at in further detail the effects of in clinical trials of the different drugs in terms of brain atrophy parameters, you can have a look at the recent study that Professor Rovira already mentioned, the Nature Review Neurology Magnim's consensus recommendations that we recently published. And finally, I'm going to finish by telling you whether we can use these atrophy measurements as a tool in clinical practice to measure the response to the drugs that we are using, because we've seen that these drugs are able to modify brain volume in clinical trials. At the meta-analysis level, this has been very nicely shown by Maria Pia-Sormani. When looking at disability outcomes, she has been able to show, and you can see here in this graph, each blobs is a trial that the larger the effect of a drug on the presence of new lesions, the larger the effect of the drug on disability progression, and you can explain 48% of the effect of the drug on disability progression by the effect of the drug on the lesions. If you look separately at the effect of the drug on brain volume parameters, you can see here that you are able to explain 61% of the effect of the drug on disability by looking at the effect of the drug on atrophy. But if you put these two parameters together, lesions plus atrophy, what you see is that you're able to increase your predictive power, and you end up predicting 75% of the variability of disability when you put together these two variables. This is at a meta-analytical level, so using data from different trials, considering trials as a single observations. But what if we consider patients as a single observation? So this is a very seminal study by Elizabeth Fisher using data from the pivotal trial of Avonex, and they look at what happened in the 2 years of trial, and then trying to predict EDSS after 6 years. And they saw that the two variables that together were predictive of EDSS were change in atrophy and the number of relapses, so one neurodegenerative and one inflammatory parameter. This has been recently replicated by, again, Maria Pia Sormani, looking at fingolimod trials, looking at change over 2 years of brain volume and relapses. At 1 year, you can predict 73% of the effect of the drug on disability progression. And we also have published exactly the same parameters in the model to be able to predict disability progression 4 years after you started with interferon. So looking at relapses over the first year, presence of new lesions, and brain volume loss, you can predict response to therapy. Then it is not strange that brain volume loss has been proposed to be added to the different parameters that we use to score response to drugs, either in the proposed NIDA-4 using a NIDA concept, or we have recently presented that adding brain volume parameters to the RIO score, so using, let's say, RIO score 4, we are able to improve our prediction. So adding brain volume monitoring to lesions, EDSS progression, presence of relapses, you are better at predicting the evolution of your patients under therapy. So this is all what I wanted to show you. I'm not going to read the conclusions of my talk, but telling you that you could find exactly this information in our recently published Manning Consensus Recommendation in the Nature Review Neurology, the paper that the effort that was led by Professor Rovira and the whole Manning study group. And I want to finish by thanking all my colleagues at the MS Center of Catalonia, Cencat, Xavier Montalban, Marc Tintoret, and the leaders of most of the research that have been published by our own lab, Francisco Pérez Miralles and Anca Vidal Jordana, and also especially to Àlex Rovira, Deborah Pareto, and all other co-workers at the MRIT. Thank you very much.
After these two fantastic presentations, two absolutely great speakers, it's an honor for me to also shortly present what we at icometrix try to do to bring atrophy measurements into the clinical routine. Basically, we have defined 5 steps, 5 elementary measures to be able to bring atrophy to the routine setting. And as time is short, I will quickly run through all 5. Of course, the presentation and the webinar will be accessible later onwards, so in case you want to look at them in details. First, of course, is an important requirement is the regulatory approval. Our software IcoBrain is approved in the US, in Europe, in Canada, Brazil, Australia, Japan, and India. So that's the first checkbox to be made. Second requirement is to represent the atrophy measurements in an easy to interpret way. And for that, we developed our 2-page IcoBrain MS report, where the first page focuses on the lesion activity and the second page on the brain atrophy. So let's zoom a little bit into this second page. Second page starts with the volume measurements of the whole brain volume and the gray matter volume, and also the normative references. We have the range there and the normative percentiles. And then we continue with measuring the brain atrophy. And we do that in an annualized way, so that allows to more easily compare the values with values in a normative reference database, which we also show as a last row in the report. Focusing on this last, we compare the values with a normative reference, and as already mentioned by Professor Rovira, it's important to do head size normalization and to do a matching for age and gender. And this age effect is shown in these graphs on this slide, where you see that the whole brain atrophy is about 0% around 25 years of age, and it increases further up to 0.3% for ages above 75 years. To also support the interpretation, we also provide a pre-populated reporting template, which contains some standard language on the brain atrophy measurement, which is underlined in green here at the bottom of the page. The third measure to make sure that we can apply atrophy in a clinical setting is to measure reliably. And for that, we have developed an algorithm that includes lesion filling and is a registration-based approach. Both of the concepts are referred to by Professor Rovira as important. Indeed, lesion filling improves the accuracy of the segmentations and hence also of the atrophy measurements. And the registration-based technique, which is a longitudinal technique, gives a higher precision. It means a higher reproducibility compared to the segmentation-based methods only. I also want to add that we do a skull-based affine registration, so we are able to compensate for small distortion differences between the two scanners. What is also very important, as also mentioned by Professor Rovira, is that the tools should be validated. Here we show the results of the validation done and published in 2016, where we established the test-retest measurement error, where MS patients were put in the scanner, pulled out of the scanner and put into the scanner again. And we expect, of course, no atrophy there, and all the atrophy measured is actually the software-related error. And we can see here that the errors reported are very low. You can see that for the whole brain volume, we measured 0.13% measurement error, which is in line or even slightly better than the state-of-the-art Sienna software, which is used in many clinical trials. Also in that paper, we investigated the effect of normal physiological variation, which was also touched upon by Professor Rovira. There we also show that in case the physiological variations are normal, the error is quite limited, in this case 0.19%. It's of course also important to have independent validation. The software icobrain Amass has been validated by groups in Sydney, in Liège, in Amsterdam, and in Milano, and the references can be seen on the right of the slide. Fourth important point to allow the use of atrophy measurements in a clinical setting is the integration of the solution into the clinical workflow. And for that reason, we have chosen to offer icobrain as a background service. That means that the analysis, including the atrophy measurements, are done in between the acquisition of the scan and the reading of the scan. That means that the radiologist has the original images together with the quantitative results and the annotated images at his availability at the moment he starts reading. And then finally, we include a very important step, which is the quality control step. Because we have been able to show that icobrain Amass is reliable under differences in age, gender, head size, distortions, and normal physiological conditions, and even some limited acquisition differences. It's still recommended to manage scanner-related severe physiological and Amass-related factors, as was also outlined by the presentations of both Professor Sastre-Garriga and Professor Rovira. And for that reason, icobrain Amass includes an automatic as well as a human visual quality control, including automatic assessment of scan alignments, scan similarity, which is important when the acquisitions are not exactly the same, for contrast, for artifacts and outline. Also, we do visual inspections of the scan quality, the segmentations performed by the algorithm, and the registration, which is, of course, key when we do atrophy measurements. This results then in a quality remark and a consequence. And this consequence can be categorized in 4 categories. Either there is no impact on the measurements, there is a minor impact on the measurement, a moderate or severe impact. And depending on the time between the different scans, the use of the measurements in clinical routine is different. In case of no remark, meaning that the algorithm did what it was supposed to do, we recommend you to use the values, and it's safe to use the values. In case there is a minor impact, we recommend to be very careful, especially if the time between the scans is between 4 months and a year. If the time difference is larger, we can assume it's reliable, and also when multiple time points are acquired, so more than 2, it's still to be considered reliable. In case of moderate consequences, if there is a short time window between, we do not recommend to use the measurement. If it's longer than 1 year, we recommend to be careful, and if it's multiple time points, it still can be reliable. An example of this is shown on this graph, where you see a long atrophy trajectory of a patient. And you can see also in the middle, there might be a jump that might be either a true positive effect, or it might be due to some scanner-related, MS-related, or physiological-related effect. But by measuring the whole trend, which you can see here, you can still draw the right conclusions. In this particular case, the lines between the trajectory and the normal lines are diverging in the beginning, and there is some normalization in the atrophy, more or less at the age of 47 years old. So with that, I would like to end my presentation.
Nothing left to say here, then thank you very much to the speakers, and thank you also very much for attending. Please do subscribe on our website to stay up to date about any upcoming webinars. Have a wonderful rest of your day and stay safe.